My name is Ho-Sik Shin from Goshin University Gospel Hospital. It is because of God's extra help that I'm able to present at this precious conference. I'd like to thank the Minister of Health, Nation, Religion, Kingdom of Cambodia for inviting me and two professors who chaired it. Today's topic is immunosuppression in kidney transplantation. We will cover key strategies for immunosuppression in kidney transplantation. Induction for early rejection prevention, maintenance therapy for balance, and adjunct option for high-risk cases. We will also highlight the importance of medication adherence to ensure the long-term graft success. First, I'll give you an introduction. The development of immunosuppressive medication has permitted the advancement of the field of transplantation by controlling the aggressive immune response that would otherwise destroy the allograft. Today, I will present on the most common immunosuppressive medication being in transplantation, their mechanism of action, dosage, and side effect. Let's turn to an induction therapy. Induction therapy offers a strong early immunosuppression, reducing acute rejection risk and delaying the calcineurin inhibitor use. However, it's costly and raises the risk of infection and malignancies. Let's talk the induction agent. ATG works by depleting lymphocytes through the complement-dependent cell lysis, but since it's a rabbit-derived, cytokine release syndrome is a key concern. Basiliximab, a humanized anti-CD25 antibody, targets the interleukin-2 receptor. It is often used for patients with a history of cancer, severe infection, low immune risk, or prior bone marrow transplant. Induction agents for kidney transplant include basiliximab, ATG, and alemtuzumab. Basiliximab targets the interleukin-2 receptors, has minimal side effect, and is not lymphocyte depleting. ATG depletes the lymphocyte but carries higher risk like cytokine release and malignancies. Alemtuzumab, a CD52 antibody, offers prolonged depletion but may increase the cancer risk. It is chosen based on the patient risk and the treatment goals. In kidney transplant, high-risk patients get thymoglobulin or alemtuzumab with tacrolimus, MMF, and steroid. Low-risk patients may get basiliximab or no induction with the same medications. This tailored plan balances rejection, prevention, and safety. This slide shows peripheral T-cell depletion after the ATG induction. T-cells are significantly depleted from the periphery and only start to recover around 6 months post-transplant, especially longer in the older patient. Question: which of the following are potential side effects of a rabbit anti-thymocyte globulin? Which one? Yes. Potential side effects of ATG include leukopenia, hypertension, fever, serum sickness, and thrombocytopenia. That is not a typical side effect. Please identify the antigenic target of the agent below. Yes. Alemtuzumab target CD52 on the T cell, ATG target the multiple T cell antigen, and the basiliximab target the interleukin-2 receptor blocking T cell activation. Next, I'll give you the maintenance immunosuppression. Maintenance immunosuppression is key for long-term rejection prevention. It targets T cell using combined agents like tacrolimus, myclophenolate mofetil, and steroid to boost effectiveness and reduce the side effect. Those vary based on the patient risk. This slide shows the immunological risk assessment. Low-risk patients are older with no HLA mismatch or autoimmune disease. High-risk patients are younger, may have a prior transplant, high PRA, or aggressive autoimmune disease. Cancer infection risk should also be assessed. Maintenance immunosuppression in kidney transplant include CNI like cyclosporine, tacrolimus. Tacrolimus FK is superior for graft survival with better potence and fewer side effects. mTOR inhibit block the lymphocyte response, offers anti-cancer effect, and have antiviral properties. Steroid reduce cytokine expression, lowering the inflammation and the T cell activation. Tacrolimus block calciurin by binding FKBK12. It is usually started at 2 mg twice daily with through targets of 8 to 10 nanogram per ml in the first 6 months. Please watch out. Absorption can increase with diarrhea or bowel inflammation. Calcineurin, cyclosporine blocks calcineurin by binding cyclospilin. The starting dose in about 9 mg per kg per day with trough targets of 200 to 300 nanogram per ml in the first 6 months. Please be cautious. Combining cyclosporine A with simvastatin or amlodipine may raise the rhabdomyolysis risk. mTOR inhibitors like sirolimus and everolimus block the cytokine signaling, offers anti-cancer and antiviral benefit, and inhibit VEGF. Sirolimus starts with a 6 mg load, while the everolimus is 0.75 mg twice daily. Avoid use if GFR less than 40 or or proteinuria more than 500 mg per day. Corticosteroids reduce the inflammation by inhibiting cytokine expression like interleukin-1 and interleukin-2. Typical doses are at 5 to 10 mg daily. Long-term use is linked to the higher death risk from the CVD or the infection in years 2 to 5 after transplant. Azathioprine is converted to 6-mercaptopurine, inhibiting DNA, RNA, and protein synthesis. Typical dose is 50 to 200 mg daily. Side effects include leukopenia, hepatotoxicity, and nausea. Please watch out for the serious interaction with allopurinol and febuxostat. Myclophenolate mofetil inhibit the DNA synthesis in the lymphocyte. The usual dose in the 1 gram BID or 720 mg BID for enteric coated MMF. MMF absorption dropped by up to 40% if taken with antacid or the calcium supplement. Belatacept blocked the B7 ligands to prevent the T cell activation. Initial dose is 10 milligram per kg at transplant, followed by maintenance doses of the 5 milligram per kg every 4 weeks. Avoiding the EBV negative patient due to PTLD risk and use caution in the tuberculosis and endemic areas. This table outlines the side effect of the immunosuppressant. Cyclosporin and tacrolimus pose the high nephrotoxicity risk. mTOR inhibitors cause severe dyslipidemia, while prednisolone raised the glucose and osteoporosis risk. MMF is linked to significant GI side effects and leukopenia. Its medications, the profiles help guide personalized treatment choices. All these frequent side effects of tacrolimus except please choice. Yes, proteinuria is not a common side effect of tacrolimus. Frequent side effects include hypomagnesemia, tremor, hyperkalemia, hyperglycemia, and hair loss. All of the following are important drug-drug interaction except please choice. Yes, tacrolimus pravastatin is not a significant drug interaction. Important interactions include azathioprine allopurinol, cyclosporin fluconazole, myclophenolate omeprazole, tacrolimus ritonavir, and cyclosporin rifampin. Please identify the antigenic target of the agent below. Yeah, belatacept blocks the CD28. Tacrolimus inhibits calciurin. Sirolimus targets mTOR. Let's turn to adjuvant therapies post-transplantation. This diagram illustrates antibody-targeted therapy used to manage antibody-mediated rejection in transplantation. Rituximab for B-cell depletion, the bortezomib for plasma cells, IVIG to neutralize antibody, pheresis to remove them, and eculizumab to block complement injury, all helping prevent rejection. Eculizumab blocks C5 cleavage to prevent the formation of the membrane attack complex and reduce endothelial injury in AMR. The dose start in 1,200 mg IV, followed by 600 to 900 mg weekly. Key risks include meningococcal infection requiring vaccination prior to use. It is also extremely expensive. Rituximab is a monoclonal antibody that targets the CD20 on B cells, helping destroy them through the immune response or direct cell death. Intravenous immunoglobulin is the plasma-derived therapy made from the antibodies pulled from thousands of donors. In transplant, it helps control the immune response, utilize all our antibodies, and lower the risk of antibody-mediated rejection. IVIG works in a few key ways. It utilizes HLA antibody to block the complement activations that inhibits B cells through the Fc receptors and prevent dendritic cells from the maturing and functioning. IVIG is given at 2 grams per kg of body weight monthly for up to 4 doses, with 4 monthly doses. It can moderately reduce the PRA, improving transplant rate from the 70% to 35%. It is suitable for deceased donor candidate, but may be less effective against the strong anti-HLA antibodies based on the experience from Johns Hopkins and Mount Sinai. Bortezomib is a proteasome inhibitor that blocks cell garbage disposal, reducing the antigen processing, cell cycle activity, and cytokine production. The usual dose is 1.3 mg per square meter IV on day 1, 4, 7, and 10. It can cause dose-related neuropathy, so pre-medication with methylprednisolone is recommended 30 to 60 minutes before infusion. Plasmapheresis removes about 65% of intravascular immunoglobulin G, helping reduce harmful antibodies in the condition like the AMR. However, antibody level can rebound by 35% within 1-2 days. Plasma is replaced with the saline, the albumin, and sometimes with fresh frozen plasma to maintain the balance. It is often combined with IVIG, rituximab, or other immunosuppressants for better immune control. Plasmapheresis is generally safe, but the risks include bleeding, low platelets, and hypocalcemia from the citrate or fresh frozen plasma. Allergic reaction and drug removed can also occur, so careful monitoring is key, especially in the transplant patient. Plasmapheresis removes a large amount of immunoglobulin G, but the antibody levels often rebound within 1 to 2 days as they shift from the tissue and the B cell keep producing more. To manage this, IVIG, rituximab, or the B cell therapies are often combined with plasmapheresis and transplant care and AMR treatment. Plasmapheresis clears the large molecule like IgG, IgM, and albumin, which hemodialysis cannot remove. While the dialysis targets small molecules like BUN and creatinine, plasmapheresis is a key for removing antibodies, making it crucial in transplant desensitization and autoimmune disease care. The BWH, Harvard Medical School protocols for highly sensitized kidney transplant patients include plasmapheresis and IVIG to lower the alloantibody starting 7 days before the transplant. Rituximab depletes B cell, and the induction therapy includes thymoglobulin and steroid. Maintenance is with tacrolimus and MMF. This reduces rejection risk and help make a transplant more feasible. All of the statements about the mechanism of the action are correct, except please choice. Yes, IVIG does not stimulate the B cell via Fc receptor, so that the statement is incorrect. The rest are correct. Bortezomib targets the plasma cell, eculizumab blocks the complement, rituximab targets CD20 on the B cell, and the plasmapheresis filters immunoglobulin. The common side effects of IVIG include all the below except please choice. Yes, liver failure is not a common side effect of the IVIG. The usual side effects include fever, chill, volume overload, hemolysis, and renal failure. Let's turn to medication non-compliance. Non-compliance in kidney transplant patients affect 15 to 40% and significantly raise the risk of graft failure. Signs include missed appointment, fluctuating drug level, and unexpected rejection. It is most common after the 24th month and can increase the graft failure risk by 7 times. Early intervention is key for better long-term outcomes. Risk factors for non-adherence in kidney transplant include young age, lack of the social support, mental health issues, complicated medication, and financial struggles. Long-term transplant patients also face increased risk, making early intervention key to improving adherence and graft survival. To improve the medication adherence, try linking medication to daily activity like meals or the bedtime. Use the pill organizers and set alarm or the voice reminders. These simple steps can boost adherence and lead to the better long-term transplant outcome. I'd like to conclude with the several remarks. Immunosuppressive therapy is crucial for kidney transplant survival. Induction agents like ATG, alemtuzumab, and basiliximab reduce the early rejection risk, while the tacrolimus, cyclosporine, mTOR inhibitor, MMF, and steroid provide long-term immune suppression. In case of AML or high risk, treatment like eculizumab, rituximab, and bortezomib can help. Non-adherence increases rejection risk, but reminders and patient support can improve the outcomes. Thank you for your attention.